Hey everyone, welcome to this detailed explainer. Today we're diving into a topic so incredibly complex that it usually means hours of dense reading, the spinal cord's blood supply. But hey, our goal today is to act as your ultimate textbook replacement. We're going to clear up these concepts for you once and for all, with absolutely zero skipping of important points, so you literally won't even need to open the book after this. We are unpacking the exact wiring of this incredible system, top to bottom.
Okay, let's just quickly glance at today's syllabus. We're going to cover 1. The core spinal cord arteries, 2. The cervical and thoracic supply, 3. The famous artery of Adamkiewicz, 4. Posterior arteries and the vasocorona, 5. The mid-thoracic watershed zone, and finally, number 6, some notable normal anatomic variants. Let's get right into it.
So, starting with Section 1, core spinal cord arteries.
What's super fascinating about this axial view is how it perfectly anchors our spatial geography, right? Down at the bottom, which is the ventral side of the cord, sits the solitary anterior spinal artery. This thing is the absolute workhorse. It feeds the entire front 2/3 of the spinal cord. And you see those tiny branches diving straight up into the center? Those are the sulcal arteries, and they have a very specific job, supplying the anterior horns of the gray matter. Basically, if you lose that anterior spinal artery, you lose the primary motor function of the cord. It's that critical. Now, comparing the front to the back, it's honestly like looking at two totally different design philosophies. On one hand, you have the anterior spinal artery. It's highly structured, a super well-defined power line formed very predictably by the junction of two branches coming right off the vertebral arteries. But then you contrast that with the paired posterior spinal arteries. Instead of that tight top-down structure, it's a much looser, highly variable network, and it's fed by anywhere from 10 to 23 different radicular branches. Totally different vibe. Moving down the line to Section 2, cervical and thoracic supply. All right, so a really crucial point here is distinguishing between vessels that just happen to be in the neighborhood and the vessels actually doing the heavy lifting. There's this common misconception that every radicular artery accompanying a nerve root from the aorta is feeding the cord. Actually, scratch that. The reality is most of them contribute very little flow to the spinal cord itself. The real work for the anterior cord is handled by just 6 to 9 major radiculomedullary arteries, which I strategically but variably located down the spine. Let's map out the exact origins of these primary radiculomedullary megafeeders in the upper spine, because there are some vital patterns here. At C3, the feeder arises from the vertebral artery. At C6, it usually comes from the deep cervical artery. C8 originates from the costocervical trunk. And down at T4 or T5, we've got another T feeder. But here is a clinical detail you absolutely cannot afford to skip. Roughly 10% of the population completely lacks an anterior radicular artery in that lower cervical spine around C6. I mean, just imagine the implications if a surgeon is operating in that specific area without knowing that.
Which brings us to Section 3, the artery of Adamkiewicz. Let's rapid-fire some essential stats here, because this massive feeder comes up constantly on exams and in real-world practice. So the artery of Adamkiewicz, also known by its very dramatic Latin name, the arteria radicularis anterior magna. It acts as the main lifeblood for the spinal cord from about T8 all the way down to the conus. Statistically speaking, it's located on the left side of the body in about 80% of cases. And for 85% of people, it plugs in somewhere between T9 and L2, usually between T9 and T12. For the remaining 15%, it plugs in way higher, like T5 to T8. But in those specific cases, they'll usually have an extra supplemental radicular artery further down to help carry the load. Now, if you're ever looking at an angiogram, identifying it is all about finding its signature shape. When the artery of Adamkiewicz meets the anterior spinal artery, it doesn't just cleanly merge, it actually splits. It gives off this tiny cephalic branch pointing upwards, and then a much larger caudal branch that dives intensely downwards. That sharp downward turn, it creates a highly characteristic, almost elegant hairpin appearance. It's a dead giveaway. Tracing these longitudinal pathways really builds a complete picture of everything we've just talked about. Look up at the top. You've got the vertebral arteries dropping down to feed the C3, C6, and C8 branches. Then you trace the aorta downward, and you can see that T5 feeder bridging across. And prominently in the lower thoracic spine, boom, there's the artery of Adamkiewicz, complete with that sharp downward hairpin turn we just mentioned, taking over the massive job of perfusing the lower cord. All right, Section 4, posterior arteries and the vasocorona.
Remember how we established earlier that the posterior spinal arteries are this kind of tenuous, loose network fed by 10 to 23 tiny branches? Well, they don't operate in total isolation from the front of the cord. The brilliant evolutionary design of the spine includes this vital bridging circuit called the vasocorona. It's an anastomotic ring that acts as a circumferential bridge, literally wrapping around the outer perimeter of the spinal cord. It allows for critical crosstalk and connection between that heavy-duty anterior grid and the multi-branched posterior network.
Moving on to Section 5, the mid-thoracic watershed zone.
So, let me ask you a question. Based on the exact spacing of the radicular feeders we just mapped out, where do you think the entire system is most likely to collapse if a patient has a massive drop in systemic blood pressure? Take a second and think about the grid we just drew. Well, if you guessed the mid-thoracic region, you hit the nail on the head. Because it sits right in the middle, between that dense cluster of cervical feeders up top and the massive artery of Adam-Kivich down below, this mid-thoracic area relies almost entirely on just that single T4 or T5 plugin we mentioned earlier. This creates a really tenuous watershed zone. It's at the absolute fringes of the territory covered by the major pumps above and below, making it highly susceptible to vascular insults, ischemia, and infarction. And finally, Section 6, notable normal anatomic variants. You can kind of think of the arcade of Laserthus like a neat little anatomical bow tying the whole shebang together. It's a completely normal anatomic variant where instead of just fading out, the anterior spinal artery actually wraps around and directly joins with the paired posterior spinal arteries right at the very tip of the spinal cord, the conus medullaris. It creates this perfect, elegant closed-loop circuit right at the termination point. So as we wrap up this explainer, I really want to leave you with a provocative thought that brings all this anatomy straight into the operating room. Considering just how fragile that mid-thoracic watershed zone is and how unpredictable the exact location of the artery of Adam-Kivich can be, how might this intricate wiring diagram completely alter a surgeon's approach to an aortic aneurysm repair or a complex spinal fusion? When you realize that a single clamp on the aorta could literally shut off the power grid to the lower half of the spinal cord, this anatomy isn't just textbook trivia anymore, right? It's literally life and death. Keep that in mind, review this explainer as your complete textbook replacement, and I'll catch you in the next one.